Good evening, everyone. Welcome to what every parent should know about the female athletic triad. My name is Dr. Rachael Polis, and I'm going to introduce you to Dr. Ann Colton.
Hi, everybody. My name is Ann Colton. I'm an orthopedic surgeon with Premier Orthopedics. My office is in Broomall. I take care of a lot of female athletes. And again, tonight we're talking about the female athlete triad. I am sports fellowship trained from Rush University in Chicago. So I take care of sports athletes. Basically, I do either surgical treatment on them or non-operative treatment, depending on what their pathology is. So we can talk a little bit more about that in a little bit. Rachel?
So my name is Dr. Rachael Polis, and I'm a pediatric and adolescent gynecologist. I'm an OB/GYN who did additional fellowship training in pediatric and adolescent gynecology. I'm often asked, what is peds and adolescent GYN? And so peds and adolescent GYN is essentially a bridge between pediatrics and adult gynecology. Oftentimes, pediatric or adolescent patients, their gynecological conditions will present differently than an adult. And so I see girls from birth to 25. My locations, I'm a part of the Crozer-Keystone health system, and I see people in Broomall, Upland, and in Media. This area is particularly of interest to me because I see a lot of female athletes. So tonight, we're going to be talking about the female athletic triad. And so what is that condition exactly? So this is a medical condition that is seen in physically active females. And there's three main components to this condition. So the first one is there's low energy availability with or without disordered eating. What does that mean? That means that an athlete is not getting enough energy to fuel themselves appropriately. And it might be that they might not know this, or they might have disordered eating, which means like an underlying eating disorder. Two, they might have a menstrual dysfunction, meaning that they're not having a regular menstrual cycle. And three, they have low bone density, meaning that their bones aren't as strong as they should be. In a healthy athlete, there's really an optimal balance between energy availability, bone health, and menstrual function. And what is optimal energy? That is when your dietary intake minus your energy expenditure leaves for adequate energy for your remaining body functions. So all female athletes, it's really important that they're assessed for this triad. And if you identify one of these components, that it warrants a further evaluation. Mm-hmm. So next, we're going to talk about some warning signs and symptoms. So the most common thing that I see in my practice is patients presenting with menstrual dysfunction. So what is a normal menstrual cycle? So girls should have a cycle in the adolescent age group between 21 and 45 days. And their cycle shouldn't last longer for a week. But when girls present with irregular cycles, infrequent cycles, or an absent menstrual cycle, meaning they've never had a period, this warrants further evaluation. So for example, a teen, if she hasn't had a period by age 15, if she hasn't had a menstrual cycle 3 years after breast development, or if by age 14 in a physically active teen who's overly exercising or is an eating disorder and hasn't had a period, that too needs further evaluation. You know, in these adolescent patients who present with menstrual dysfunction, it essentially is a condition called hypothalamic amenorrhea, meaning that the brain isn't talking so well to the ovaries anymore, and there's not adequate estrogen production. And estrogen is really important because it helps to both build bone and also reabsorb bone reabsorption. And peak bone mass usually occurs in adolescent. Dr. Colton, if you want to continue to talk a little bit about some of the bone health in adolescence.
Absolutely. So in my practice, usually I don't see athletes with this condition until they've had a serious injury, such as a stress fracture or a real fracture or a stress reaction or shin splints or something like that. And that's when I refer often to a pediatric gynecologist like Dr. Polis. What's really important for you to understand as a young athlete is that their peak bone mass is finished at about age of 18. So we're really starting to make our bone stores as young females in between the ages of 11 and 14. So that is the time of a young woman's life when they need to have nutritional optimization, meaning that they need to have a well-balanced diet. They can't be calorie restricting or things like that, because once you don't have enough bone, by the time you're 18, that's it. That's all that you get for the rest of your life. And after age 18, your job is to maintain it or else you lose it. So your job leading up until the age of 18 is to make sure you build up as much bone mass as possible. And we do that through a good nutrition, through weight-bearing exercise.
So one other symptom that I might see also in the practice is something of disordered eating. So this could be anywhere from dieting to different abnormal eating behaviors. This is actually fairly common in slender built females. So, and it can actually occur between, there's been many different quoted studies, but anywhere from like 16, anywhere up to almost 50%. So it's more common than you might think. Disordered eating could be just restricting your intake for the purposes of becoming leaner. And some examples of these are anorexia, bulimia, or binge eating disorder. For individuals that have these conditions, it's really important that they see a mental health provider who has experience in eating disorders. Some of the long-term effects in terms of athletes that have the female athletic triad include reduced athletic performance. So they're not going to perform at their best. If you're under fueling and you don't have the appropriate macronutrients, it can affect many other organ systems, your cardiovascular system, your renal system, your central nervous system, and your immune system. Girls with low energy availability that have disordered eating can face some psychological distress. They can have increase in depression, low self-esteem, and also anxiety. And then what Dr. Colton was talking about before, there's the risk of osteoporosis and fracture. Dr. Colton, what athletes typically suffer from this condition most commonly?
Most commonly would be the athletes who have some type of a physical appearance related to their performance, such as gymnasts, figure skaters, dancers, even runners, because they need to kind of have a low weight and they're burning calories quite a bit. So I would say that those are probably the biggest ones. And the biggest ones I see with stress injuries are certainly the runners, any type of people who are doing a very high impact exercise. So the runners are probably a very high injury profile because they are not only high impact exercises, but they also tend to have a low BMI. So another thing that we need to talk about is really what BMIs are healthy for young ladies. And so there's kind of been some talk about what the cutoff is. I don't know what your experience has been, but 17.5 is sort of where is almost like a cutoff. So if it's below that, it can be very concerning that there's some nutritional deficiencies. If it's somewhere above 18, that's kind of where we want our athletes to be, especially so they have enough energy availability to perform their sport. You want to explain anything about the BMI? I mean, I think that's a big issue.
Well, there's been a lot of studies that have demonstrated that when there is weight gain, menstrual function can return to normal. And so even just a couple pounds can shift the menstrual cycle to become regular again. So when we do evaluate patients, one of the things that we're looking at is their growth curve to see where they fall from one visit to the next. I think it's also important to note that this isn't just particular to those sports that Dr. Colton mentioned, that this can include any sport. And the International Olympic Committee proposed changing the name to relative energy deficiency in sports. And the reason they did this was because they wanted to identify that this can also occur in males. And it also can affect many additional components, some of which we talked about briefly before, that it can affect the immune system and your cardiovascular health and your protein synthesis and your metabolic rate. So I think it's important to recognize that this can happen in any athlete. And it's something that at your pediatrician's visit or when you're seeing your gynecologist or at your sports physical, these things should be assessed.
Absolutely.
So some of the things that when a patient comes into the office, some of the things that I'm evaluating for, and a part of the screening for the female athletic triad includes identifying what their weight is. So how does the athlete, what is their goals for their max weight, their minimum weight, and their ideal weight? So I think that's something important to talk about. What's their menstrual history? So what is their pattern like? And also, how old were they when they had their first period? And how old were they when they started developing secondary sex characteristics? For example, breast development. What's their exercise routine like? What are their eating habits? What is their dietary history? What meds are they taking? And is there any history of an eating disorder? Also talking about laxative and diet pill usage, their sexual history, if there's any substance abuse, and also identifying if there's any depression as well. Most of the time, physical exam findings are normal. We talked about briefly that we do look at the growth curve. If a patient really has low estrogen, sometimes you can see signs on exam. For example, with their secondary sex characteristics not developing appropriately, so not having breast development. And in patients that have an eating disorder, particularly anorexia, you might see a very low heart rate. You might see hair loss or a really dry skin, or actually ankle or leg swelling. Most of the tests that we order in my office most of the time is a pregnancy test. And then checking some female hormones, something called a follicle stimulating hormone, checking your thyroid with the thyroid stimulating hormone, and then also checking breast milk hormone called prolactin. Additional labs might be added based on the physical exam findings. And then also, I think it's important to note in adolescent patients who are sexually active, it's really important that they have STD testing yearly and with each new partner for gonorrhea and chlamydia. So how do we treat the female athletic triad, Dr. Colton? What's kind of the main intervention that we do?
Well, so as an orthopedic surgeon, so luckily I'm not treating many of these athletes like you are. So in my estimation, the one thing if we get to a young female athlete before they're age 18, I think in my practice, we're working on more of bone health. So we're making sure that they are doing weight-bearing exercise because that actually helps with bone development. But if they're doing too much, that can also be detrimental. We want to make sure that their laboratory studies are okay, that their calcium, their vitamin D levels are important. Because in situations where there is low estrogen, females can actually decrease absorption of calcium through the gut, so through your diet. And then they actually let go of more calcium in the urine if you don't have a lot of estrogen circulating around. So I do certainly take a menstrual history when I have young ladies with stress reactions and stress fractures. So I think one of the things we talked about is that we need somebody to see them for nutrition. That is extremely important. So anybody with any dietary concerns and anybody who is expending that kind of energy as an athlete needs to really tie the nutrition piece in very importantly. So bone health wise, I think making sure their laboratory studies, their vitamin D levels are normal, making sure their calcium levels are normal. So we can kind of treat that in an orthopedic setting, or we send it to their pediatrician.
So like Dr. Colton was saying that, the main goal of treatment is really replacing their energy imbalance. And so, they either need to adjust their energy expenditure, how much they're exercising, or how much energy is available with kind of the food they're intaking. So I refer a lot of patients to see a sports nutritionist. I encourage my patients to keep a food diary for a couple of days so that they can bring that with them at their visit. In addition to keeping a menstrual diary, I think is very helpful too. So the main kind of treatment is just supportive in nature. We're not using medications. And the real goal is to restore a regular menstrual cycle. Like we were saying before, we think about the menstrual cycle as a vital sign, just like blood pressure and heart rate. And when the menstrual cycle is not normal, it means that there's some sort of medical condition going on. In this case, the female athletic triad. For patients that have disordered eating, underlying eating disorders, it's really important that they get into cognitive behavioral therapy and meet with a behavioral specialist that deals with those mental health issues. I think that's really key. And and as Dr. Colton had mentioned before, the also goal is weight gain. So in those patients that have a low BMI, one of the predictors of maintaining a menstrual cycle um, is weight gain. And so I think that's important also. Medication therapy is very controversial. Birth control pills, combination hormonal contraceptives have estrogen and progesterone in them. And it's been found that oral contraceptive pills can maintain the bone density. So it's not going to improve it if it's already low, but it's been found to help maintain it. And so the issue with using birth control pills is, though, you give patients a false sense of security. So they're now going to start having a regular monthly cycle, and the female athlete's going to think, oh, everything's great, it's normal, when in actuality it might not be. And so I think it's really important that we kind of weigh the risks and benefits of when to use oral contraceptive pills. Now, a caveat to this, and it's important to also think about, is if an adolescent is sexually active, then they need to be on some sort of contraception to help against pregnancy. Particularly once they start to restore their energy balance, they're actually going to ovulate prior to having a regular menstrual cycle, and this puts them at higher risk for pregnancy during this time. So it's an important thing to have a discussion about and to weigh the risks and benefits of when it should be used as a treatment modality.
Mm-hmm.
Dr. Colton, do you want to talk a little bit about how much vitamin D and calcium adolescents need?
Sure. So the typical numbers are approximately 1,000 milligrams of calcium per day, somewhere between 1,000 and 1,300. Supplementation is, again, controversial. We really like our athletes to get their vitamin C and calcium and vitamin D levels through food, cruciferous vegetables, like leafy green type stuff, like broccoli and spinach and things like that. So about 1,300 milligrams of calcium, about 800 to 1,000 of vitamin D is kind of where I like to see it. If I see an athlete with a fracture, a stress fracture, I do typically check those numbers to make sure that their levels are okay. And we do end up supplementing athletes if they're low. However, if they're not low, I just make sure that they're maintaining with a really healthy diet that's well-rounded. I think nutrition is key, which actually brings the point where this is a kind of a team approach. So we're talking about the treatment of a female athlete triad. It really is a team approach. No parent should feel that they alone have to manage their daughters or their sons' nutritional deficits or their daughter's menstrual issues. So, that's why there are experts like us, like Dr. Polis, to see your daughter for a menstrual issue, and there's a lot of sports nutritionists out there that can really help. And luckily for me, that I don't see athletes, with this condition all the time. The problem that I see is that when it's almost too late. And so that really goes into more of an offshoot of this, is the sort of the chronic overtraining issues and the chronic overuse injuries. So we don't have to really get into that today, but one thing that I really want to emphasize is that, in this era of athletes playing year round, it is really important to take rest times. And I think one of the hardest things that I have when an athlete is injured or has sort of a chronic tendonitis or even a stress reaction or a stress fracture is to sit them and to not allow them to participate in their sport. As a sports medicine surgeon, I want my athletes to be out there playing, of course, but taking a break is extremely important. Our athletes need to rest. They can't be doing the same activity over and over and over again. Our bodies just aren't made to do that. So I think one thing that everybody, a team, coaches, athletic trainers, doctors, we all need to be in this sort of the same vein where we need our athletes to not overtrain and to make sure that they're protecting themselves from overuse injuries and stress reactions and stress fractures. So I think part of the treating the female athlete triad that we're really trying to emphasize here, it is a team approach, and it comes from the parents, the coaches, the trainers, the doctors, the nutritionists. And I think that is something that I think all parents can kind of welcome, I think.
And, tying into what Dr. Colton was just saying, there is something called girls return to play. And what that means is exactly is setting realistic goals of when sometimes intervention is necessary. So there's no standardized guidelines for what return to play really means. It's very individualized. But I think there are worksheets that have been created that help to identify when an athlete's at low risk, moderate risk, or high risk for the female athletic triad. And there are times that they might have to reduce their amount of athletic training or take a break. And that can sometimes be, met with just some sense of being disheartened from both the family and the athlete themselves, because this is something that they've trained for and they're passionate about. But I think that it's really important to keep this in mind, because we don't want them to have stress fractures and further damage to different organ systems. So return to play is really, like I was saying, individualized, and it's something that can be created with this multidisciplinary team: the athlete, the family, the physician, the nutritionist, all kind of coming together with standardized kind of and set goals of when this criteria is met, of when they can go back to playing at their full capacity.
Right.
The thing I think that we really want to stress today is just that education is really important. And so I think the more, we kind of empower these teenage athletes to learn about the female athletic triad, the more that they'll be aware that it's something that they need to consider and think about. I think so oftentimes the athletes I see don't even realize that they're not appropriately fueling. It's not intentional. And so educating them about this and coaches and parents, I think is really vital to making sure this doesn't occur.
Absolutely. Anyone out there have any questions? Happy to field anything. Let's see here. What else can we, let's see. We could talk about what the warning signs of a stress fracture is. So one thing that a stress fracture, they can occur any part of the body. The most common place in in female athletes or male athletes is the tibia or the shin bone, which can often be confused by shin splints, which is basically an inflammation of the lining of the bone of the shins. You can get a stress reaction, which is basically a localized stress injury to the bone itself, but it does not form a fracture line. And then a stress fracture. I kind of talk about stress injuries on a continuum because they really are that. There's sort of a minimal and a maximum. And I kind of treat things along that continuum. And rest periods depend on the severity of the injury. So a stress fracture is an actual fracture that you can not necessarily see on an x-ray, but you would pick up on an MRI or a bone scan. And that athlete needs to rest until the fracture is healed. And oftentimes we know that it's healed if it's no longer tender, if sometimes a repeat scanner is done, or an x-ray shows a healing bone. Other places where I've seen stress fractures are in the hip bone, a little bit more common in runners. Oftentimes they don't need any surgery, which is we're very grateful for. But there are some times if stress fractures are ignored, pain is ignored for months at a time, weeks at a time, anything, then the fracture can actually turn into an actual fracture that you see on an x-ray. And sometimes those need to be treated surgically. So again, the message here is that don't ignore pain. Don't ignore the fact that you haven't gotten your period in 4 months. It needs to be addressed because we want to protect you for your future athletic endeavors as well as your future as an adult. I think that's probably the most important thing is that we all, we want to make sure that you have a healthy bone, and that you have enough energy availability to do all the things that you want to do, including academics and athletics and everything. So.
Well said. Are there any questions from the audience? Anything that we've addressed that you have questions about?
Hi, Janet. Thanks for tuning in. Say hi to Megan for me. Why don't you take that one, Rachel?
Sure. So the question is, if parents believe their daughter has the female athletic triad, how should they encourage seeking treatment? So I think finding a team to help participate in care. So finding a gynecologist, a pediatric and adolescent gynecologist is definitely an option to assist in management and evaluation of why is your daughter not having a menstrual cycle. And then also assessing, is there energy deficiency, and referring on to a sports nutritionist. Or if, like I said, if a eating disorder is identified, then a mental health provider is sought out. So this is really, like we've reiterated before, a multidisciplinary approach that creates like a team that's working together. And that's really the vital part, I think, is that we're here to help you. Dr. Colton is at Premier Orthopedics, and she's available. I'm a part of the Crozer-Keystone system. Happy to see you as well if you have any concerns, and are seeking a further evaluation for your daughter.
Great question. Well, any other questions? And we can kind of.
I think we can just circle back and just highlight some key points.
Good idea.
So what are some key takeaway points from the female athletic triad that we discussed today, Dr. Colton?
So first of all, is low energy availability. So we've talked about that. That can come from either overtraining. So everybody's always talking about the calories in, calories out. So we want to make sure that they're nutritionally sound so that they can perform athletically. Low bone density. So that's something that would be picked up on. We didn't really actually talk about how that's diagnosed, but it can be picked up on a bone density scan. So that can be done if we're very concerned about that. So, and then a menstrual history. So I think having either a few months without a menstrual cycle, I think that's something that is a clear warning sign. And again, and Dr. Polis can speak to this, is you don't need to have all aspects of the triad. We're not, you don't have to, you're not a rule in or a rule out. If there's a problem in one part of the triad, we need to correct it and we need to make it better. So I think that's, it's awareness. It's that this exists and that some of the warning signs, and these are mostly correctable, especially if we get to the young athlete in time, then these are correctable issues.
Yeah, there really is an optimal balance between all three aspects of the triad. And so when one is off, it affects everything. And so it's just kind of about finding this optimal balance between all three, which is really key.
Absolutely.
Any other questions from the audience? Well, in that case, I mean, this has been really fun. I'm glad that we were able to share with you some insight into the female athletic triad. And we are available to help you if you have any, myself, if you have any menstrual troubles, absent periods or regular cycles, or menstrual irregularities. Dr. Colton's available. If you want to speak a little bit to...
Anytime. Premier Orthopedics in Broomall, we're at the Marble Commons building. We're happy to see any orthopedic issues, especially, I do see a lot of female athletes. I'm a proud female athlete myself, played basketball my whole life. So we see patients 5 days a week. We have an an urgent type of care in our office Mondays and Thursdays, no appointment needed. We also have an urgent care and media that's just orthopedics. So anybody who has an injury certainly can come and see us there. But of course, if anyone has any issues with stress injuries, the fact that Dr. Polis and I have connected over this has been very, very helpful. So I think that making sure that we do have a multidisciplinary approach to this is probably the most important thing, to make sure that your daughters and your female athletes are well protected and healthy. So.
Exactly. Well, thanks so much. It was great to speak with you tonight, and we look forward to doing something like this again soon.
Absolutely. Okay. Take care, everybody. Good night.
Bye-bye.